this week on the BackTable podcast.
It's that now we have more women arriving to menopause healthy, thriving, working than ever before. And so we have a huge workforce that really needs to feel well in order to be able to perform the functions that society demands of them. And that is really new historically for women, especially North American women. And so now we have increased life expectancy, increased working age of women. The conversation is now being had about menopause symptoms. Now the guidelines underscore its importance. All these data have accrued time and have decades worth of information because, again, the Citizens Petition was filed in 2016 and we're in 2025 right now. So all of those things together, that's where the inequity comes from.
Hello and welcome once again to BackTable Urology Podcast, your educational resource for everything urology and then some. I'm your host today, Dr. Suzette Sutherland, and I'm thrilled to once again have Dr. Yahir Santiago-Lastra with us from the University of California, San Diego. She's been our guest on a few other episodes, and most notably when I hosted her discussing issues pertaining to the gender gap in medicine, and especially in surgery and in our world of urology. And a lot of her personal efforts and professional efforts in associated advocacy for not only gender discrepancy issues, but also patient care issues. So, as I said, we have Dr. Yahir Santiago-Lastra with us. Thanks for being here.
Thank you so much for having me, Suzette.
Today is part of our larger menopause series. We are doing a number of episodes dealing with different aspects of menopause. It's become a big hot topic again because there's so much more current data available to help guide us with evidence-based medicine to help women through menopause. We did another episode with Kelly Casperson looking at the historical data associated with the Women's Health Initiative, the WHI studies, the way the information was released in 2002 and the fallout thereafter that caused a lot of fear, not only in the general population, but again, among practitioners as well, with respect to prescribing and using systemic hormone replacement therapy for menopausal symptoms. What we do know today, however, is that a lot of that fear was really misguided. The data from the WHI study was misinterpreted, and it made a huge media blitz, and thus the fallout of the fear. And there's a lot of effort being done today to try and correct that fear, but data to help support it as well. So that's really what this series is all about. So we did do another episode diving specifically in that. We're going to do another episode looking at the details of the new 2025 AUA SUFU guidelines that came out, helping practitioners understand how best to treat genital urinary syndrome of menopause, which is commonly known as GSM, right? The guidelines help guide us, but with evidence-based data, right, to show us how we should be treating these women. And today, we're going to really focus more on the advocacy component associated with the treatment of GSM. And Dr. Santiago-Lastra has done a lot of work in this area, looking at what we call the black box warning for estrogen. So I just sort of set the stage there. Why don't you take a little bit from here and explain to us, okay, well, what is this issue with this black box warning? There's a lot of media around that right now, and people don't really understand. What is a black box warning, and how is it supposed to be utilized?
Absolutely. So let's just quickly and briefly put a little bit of this into context. So first of all, this is a topic that I'm very passionate about personally. But additionally, I represent the Society of Women in Urology on the American Urological Association's Public Policy Council. So it's not just, a passionate topic for me, it's a public health crisis, and hopefully we can underscore why that is today. To better give that context, I think quickly going through the history of what I call the estrogen wars, or battling the FDA for women's health. That was coined by one of our colleagues, Dr. Rachel Rubin, and I think it's really true. It all starts in 2002. We can definitely refer to Kelly Casperson's episode on the Women's Health Initiative study, but that's when first estrogen and progestin were linked to increased cardiovascular and breast cancer risk. So then in 2003, right away, the FDA issues a black box warning on all estrogen products. Now, if we look back at that data, we can see how the data was confounded and really obscured the reality, which is that estrogen is very beneficial. In 2004, they started to notice that there was an estrogen-only study that found a small stroke risk, but no excess breast cancer risk. And then in 2016, after some burgeoning data, the National Association for the North American Menopause Society, put in a citizen's petition to the FDA to remove the black box warning. And then in 2018, the petition was rejected, and this is where we are. And the FDA at that point cited that there was a lack of well-controlled studies, and it snowballed into the issue for access that we have as a result of the black box warning today. And we can go over a little bit more about what a black box warning is and how it pertains to estrogen specifically. But I wanted to put that context out there so we know what the state of the problem is and why we're here today discussing it.
Yeah. And what we're talking about, too, is the black box warning specifically here for the use of vaginal estrogen, very local, small dose vaginal estrogen, which is different from using larger dose systemic estrogen, although I would argue the data isn't there either to show that that's harmful, but rather beneficial, which we talked about in the other episode a little bit more. But in any case, this black box warning at the first step is to try and get the FDA to separate this idea of local low-dose vaginal estrogen, what are the risks and benefits associated with that, versus the systemic, and should it be part of this black box warning. So with that, let's look into, again, I mean, we're all physicians here and providers here, mostly that are our listeners, but I don't know that people really understand exactly what a black box warning is and what its trickle-down is.
Absolutely. And I want to underscore something that you just mentioned that I think is incredibly important because it is the crux at which this problem arises. And it is estradiol. Estradiol has the black box warning. We cannot parse out vaginal, topical, low dose estrogen from systemic estradiol as far as the FDA is concerned. And that's where we are running into this issue where low dose topically applied vaginal estrogen is incredibly safe and has had none of these adverse events attributed to it. But the black box warning is for estrogen in general. And that creates the problem that we have. So going into what the black box warning is, let's really go into it so you leave this episode knowing exactly what it is. So the black box warning is the strongest safety warning that's issued by the FDA. It's intended to highlight serious risks, but it's sometimes been misapplied, and there are some historical medications that have undergone a label change. So there is possibility to change it. And then the other issue there is to understand why this is applied to certain medications. So number one, it could be because the medication confers life-threatening or fatal risk. And so the medication's been shown to cause severe adverse effects that can lead to death or permanent disability. An example of that is isotretinoin or Accutane. It can cause severe birth defects if it's taken during pregnancy. There can also be a lower risk, but still really concerning severe or irreversible adverse effects like fluoroquinolones, which can cause tendon rupture or permanent nerve damage. It can also be issued because the adverse effects perhaps are not fatal, but they're not easily managed. For example, clozapine causes a risk of severe neutropenia, and that requires frequent blood monitoring. So because that's not easy to manage, there's also a black box warning there. And then the warning usually arises from clinical trials, large-scale observational studies, or post-marketing reports showing that there are one of those significant risks. An example of that is varenicline, which is Chantix, used to have a black box warning, no longer has one. And that was based on psychiatric risks, based on case reports and post-marketing data. And it was later removed after further, more robust research showed that the warning was not applicable. And what's important to consider here is the disproportionate risk. And the reason I'm emphasizing these things is because when we put this towards vaginal estrogen, it really doesn't add up. But it has to have disproportionate risk compared to benefits. So the study may still be useful, the drug may still be useful, but only in select patients where the benefit outweighs the risks. And a great example of that are opioids. They have a black box warning for addiction, abuse, and overdose risks, but we know that we still use them in some patients because the benefit outweighs the risk.
So the crux here really is for the patient is this medicine, it might help you. We think that there's benefit to this medicine, but there's significant risks and you need to take a pause and see what those risks are, and are you willing to take those risks? That's what the black box warning is really saying.
Correct.
And so in this situation, as you said, they're lumping in all systemic estrogen with the local vaginal estrogen. And we know that regular use of vaginal estrogen, low-dose vaginal estrogen for local symptoms, there's no increase in systemic estrogen levels when women have been monitored before and after vaginal estrogen use. There's a number of those studies that have already been done. And yet that information doesn't seem to be able to get translated to the FDA, or the FDA is still not comfortable with that information. With the biggest concern, we're afraid about breast cancer. Women are so afraid about breast cancer. We are too, and we don't want to take any chances.
I think what is holding us back is really the process. And so the FDA has a process through which it handles these black box warning and label changes. And so in order to be successful in having that rescinded or pulled back, we really have to follow the process. And this is a moment in which a little bit of history is also useful. So again, in 2016, there was already something called a citizens petition that was submitted to the FDA to rescind the black box warning on vaginal estrogen, and it was denied. And so let's talk a little bit about what a citizens petition is and why it's important. But before that, I did want to highlight what the black box warning for estrogen was highlighting in and of itself. So the black box warning for vaginal estrogen, if you look at, for example, the lowest possible dose, Vagifem, right? Twice a week, the black box warning for vaginal estrogen seems alarmist when you look at it. It warns of endometrial cancer, cardiovascular disorders, probable dementia, and breast cancer. But these risks have really not been shown in these large-scale studies that we now have available. Even in 2025, we've had a recent meta-analysis that looked at tens of thousands of women and showed no increased breast cancer risk in those patients, which is excellent. But this label really hasn't changed since 2002. So that one time when they tried to change the label, it was through something called a citizens petition. And so a citizens petition is a process in which either through advocacy or through professional societies, whatever organism decides to put in that formal request to the FDA, it could be an individual, it could be an organization, it could be a stakeholder requesting that they amend these regulations and amend these warnings. It could be about updating the drug labeling, which would be excellent for vaginal estrogen to just have that underscoring that vaginal estrogen in its recommended dosing are actually very safe. All of those formulations are actually very safe. Or it could be any other regulatory action based on new evidence. For example, just removing the black box warning altogether, because what has been shown over time is that systemic estrogen is also a lot safer than the Women's Health Initiative initially led people to believe. So the citizens petition process is a key tool for advocating changes to outdated safety warnings. And so that is, seems to be the best process. But then there's another little hiccup there, another obstacle, which is that the FDA typically considers only one citizen petition per issue. And again, it's already been addressed in 2016. It's already been filed. So that means that any new petition has to be coordinated with existing efforts or pursued through alternative advocacy strategies like pairing with industry, who hasn't really requested any label changes for vaginal estrogen since this citizen petition was filed.
So can you give us some insight into why that petition was then denied when we do have updated data that shows even the pharmacokinetics of vaginal estrogen, right, does not increase systemic estrogen levels. So all of these risks that are touted to be associated with systemic, it shouldn't apply to the vaginal. Even that, again, I said is debatable, right? But why was it then denied?
Yeah, I think that in 2016, so it was denied in 2018, actually, but the citizen petition was filed 2016, 2018, it is denied. And I think the main reason that it was denied is because there weren't these large scale studies of tens of thousands of patients showing no increased conferred risk with systemic or vaginal estrogen. They felt that at that time in 2016, the evidence was really lacking to reverse the label change. And here's when another history lesson is a little bit beneficial. And it is if we look at what was accomplished with testosterone. So many urologists may be really excited to hear that in 2025, in February, the FDA actually removed the black box warning for testosterone. And that was removed following strong clinical evidence of cardiovascular safety through the TRAVERSE trial. So really quickly, the TRAVERSE trial was published in 2023. It confirmed that there was no increased cardiovascular risk with testosterone therapy, and that actually those supratherapeutic levels that we are often worried about are actually don't pair out in the literature when people are safely treated by their providers. This was a trial of about 5,000 plus men. And if we look at the studies in women published out of Denmark, if we look at the recent 2025 ASCO study through the University of Arizona, we are talking about tens of thousands of women showing no increase in breast cancer recurrence or mortality, improved survival. There was a 2025 meta-analysis that looked at 6 studies covering over 24,000 patients showing no increased risk. And so I think if we look at the great news that we received with testosterone and we look at the data that we have for estrogen, it's really no better time than now with the data that we have to request those label changes.
Yeah, I'm glad you brought that up. I want to touch on that a little bit, and especially with respect to gender issues, right, in advocacy here. And we have a bit of a paternalistic, I think, attitude still in medicine. We see it all the time. And although we want to deny it, but we still see it, right? And there's this idea that, we tolerate more suffering in women. Women have problems with their menstrual cycles, then they have pain at delivery, they have babies, and then afterwards they have more pain. And then in menopause, we have issues during menopause. And we allow that suffering to some degree. And that's really what the WHI study, the fallout of it is that, well, we know we could give you this estrogen and maybe progesterone if you need it as well, so on and so forth. But we could give you the hormones, but there's such a risk associated with it that we think for you to suffer is better, or to use non-hormonal options, which we know aren't as good, but they can be beneficial. But if we look at the men's side of things, when men go through, I'm going to say menopause, right, and end up aging in lower testosterone levels, and men start screaming about having erectile dysfunction and low libido, and then men suddenly get heard. When you made a point here, when we look at this Traverse study, it was a great thing that it happened, but it happened really quite quickly. Pharmaceutical industry jumped in, right, to pay for this study. It did have 5,000 men. It was a randomized controlled trial against a placebo. But my understanding is the primary efficacy, right, trying to look at cardiovascular risk with use of testosterone. And by the way, they used men who already had a cardiovascular risk or lots of risk factors for cardiovascular disease. So that's interesting. But they were able to make their decisions, based on only about, almost 400 patients in that primary endpoint. So although we look at it and say it was a large study, 5,000 patients, they had a lot of fallout for different reasons. This isn't the place to get into all of that. But the determinations were made on really a small number of patients, if you want to think about it, if you're looking at population-based patients, right, or studies, and then also over 3 to 5 years. And so in comparison to that, my understanding also is one of the denials that's happening today is we don't have enough data. We don't have enough data concerning the use of vaginal estrogen. And the biggest concern, Dr. Santiago-Lastra mentioned 4 concerns, but the biggest one that everyone's always afraid of is the breast cancer, right? And so they said, well, you have some of these wider population registries, population studies that you've looked at. You mentioned already the meta-analysis that's 100,000 patients, tens of thousands of patients, but they didn't go out long enough. They need to go out 10 years to make sure there's no risk of breast cancer. So why is 5 years okay for men, but women, we need a study for 10 years? Here's the inequity here, right?
Yeah. I think with any time we look at an equity issue, we tend to think, okay, who is pulling these strings to sort of hold this group back? And in this case, women. And I think that is a tip of the iceberg way of looking at inequity. So there are things, attitudes, and misperceptions about women and about women in menopause that need to change. Absolutely. And that is, there are a lot of women in the perimenopausal stage or postmenopausal stage that are hot and bothered about it, no pun intended, and really want to change the perception of what women can accomplish when they're in that era. And so that's the tip of the iceberg, I think. Then there's all sorts of society endemic epigenetic factors that lead to inequity. And I'll clarify what I'm saying. Firstly, to put estradiol against breast cancer is a worthy opponent because a lot of focus over the years and decades have been put into breast cancer research and breast cancer protection. And so a lot of people feel very, very strongly about it, and it is a scary threat to women. And so I think when you look at that risk and even discuss it or confront it to some women, many are just not comfortable. I have patients, even though I have 10, 20-minute conversations with the patients about the incredible safety of vaginal estrogen and how it can help them avoid the symptoms that are taking away their entire quality of life or even putting their life at risk if they're getting really complicated urinary tract infections. Their fear of having a breast cancer recur far outweighs their willingness to try this medication with this warning. So breast cancer is a worthy opponent there, and it's going to take some time to peel that back. And I think that's one of the biggest impetus for me being so staunchly advocating for the label change. So that's one area. The other is that it really has been a recent occurrence that we have been more vocal about genitourinary syndrome of menopause. We just had some guidelines put out by the AUA, and they are the first guidelines that underscore that low-dose vaginal estrogen is a foundational treatment for this condition. Previously, if you looked at a lot of the guidelines, there were a lot of other treatments, topical treatments, supportive treatments, pelvic therapy, etc., to treat the vulvovaginal symptoms. And estrogen was a part of those guidelines, but it wasn't underscored as the foundational first-line treatment. And now it is. And so that's a change.
I think that's a super important point that you make there, right? Foundational. I like the use of that word, right? It's really the primary treatment, the go-to, unless there's some reason absolutely why a woman can't use it, because we know the benefits so far outweigh any theoretical risks, right? There aren't any proven risks thus far. They're all theoretical. And actually, that theory has also been disproven in pharmacokinetic studies and such.
Absolutely. And I would say, I underscore this as well, it's foundational also for the prevention of recurrent urinary tract infections, which are a part of GSM symptoms, but it's really a level up in risk, right? Because that can definitely be deadly. And it's a foundational treatment there if you are postmenopausal. And I would also say that includes overactive bladder. One of our biggest supporters currently in the patient advocacy realm is the National Organization for Continence. And why? Because it's such a driver of urgency of urination and of urgency incontinence to have genitourinary syndrome of menopause, and it's included there. So that was the biggest thing too. So that you have the worthy opponent in breast cancer, then you have the lack of guidelines that stress that it's an essential treatment. So again, remember that the label change or the black box warning comes in if the side effects far outweigh the benefits. And if we haven't really underscored the benefits in any guidelines or made it a foundational treatment, like what is the impetus to change that, And then thirdly, it's that now we have more women arriving to menopause healthy, thriving, working than ever before. And so we have a huge workforce that really needs to feel well in order to be able to perform the functions that society demands of them. And that is really new historically for women, especially North American women. And so now we have increased life expectancy, increased working age of women. The conversation is now being had about menopause symptoms. Now the guidelines underscore its importance. All these data have accrued time and have decades worth of information because, again, the Citizens Petition was filed in 2016 and we're in 2025 right now. So all of those things together that's where the inequity comes from. And so you can see that the puppet masters holding the strings to pull women back is one part of the issue, but it's so embedded in how we've lived and taken women through the course of their life that to reverse that is going to take a monumental effort, which is already underway. I think we have all of our ducks in a row to do this, but it's taken many years of effort to get to this point.
Yeah, I mean, I would agree. I think culturally and generationally, women have also been part of their own problem, utilizing some of the information that we're given, right, by providers and by the FDA and so on and so forth. But there is this generational aspect to the work that we do, right, which is, well, my mom had this problem, my grandmother had this, I guess it's my lot in life, I had a few lovely babies, so ergo. But there's a whole generation of people who are coming down the pike now, getting to the menopause stage, but also even before that, who are, advocating for themselves. They feel empowered to do so and standing up and, having their voices heard, saying, this is not okay. We stress so much about longevity. How do we improve our longevity? That's what we do in medicine, right? But we want to have quality longevity. And this is a big piece of the puzzle for us. So with that in mind, let's just really quickly just spell out too, it's this GSM, genital urinary syndrome of menopause, that use of vaginal estrogen, what it's beneficial for. It's not just about sex. So many patients think that too. Well, I'm not sexually active. I don't think I'm going to be. Why do I need that? But it's about the health of your pelvic area, your genitals, your urinary system. And you already mentioned a few. Go ahead and list the things that it's beneficial for.
So vaginal estrogen benefits many ways. Again, essential treatment for genitourinary syndrome of menopause, which includes urgency, pain, dryness, dyspareunia, meaning pain with intercourse. So all of those constellation of symptoms are very adequately treated with low-dose vaginal estrogen. Again, there's nuance there because some patients will benefit from certain formulations. Some patients will benefit from estrogen, testosterone, and then you have another player entering the chat with progesterone. So there's a lot more options than even we are underscoring with advocating for the estrogen. But obviously that label change and the way that insurance covers these medications, the lowest hanging fruit really is vaginal estrogen because it's on formulary, it's cheap, and it's effective. So it treats that. In particular, I always emphasize the urgency symptoms of GSM because as we start to go through menopause and the vaginal and bladder and that whole pelvic floor area starts to show a decline in local estrogen levels, you can see that the nerve fibers sort of expand, and that can lead to a lot of these irritative symptoms that occur. So there's a neurologic sequela of having low estrogen in that area that can be really bothersome. And then you also have the traditional route of estrogen, which is it stimulates the vaginal cells to produce lubrication. That lubrication is really high in nutrients like lactose 4, lactobacilli, which compose a really important part of our microbiome in the pelvic floor, which is essential for the prevention of infections. So you can already see how all of those things come together to provide huge benefit for women. And if I were to say, what's, pie in the sky, what would you love to see? I would love to see women being offered vaginal estrogen a priori without, having to ask for it because they have symptoms when they start to reach the age of perimenopause. So they know that that's a great low-dose preventive treatment for genitourinary syndrome of menopause so they can continue being sexually active and feeling good about themselves and their pelvic floor. That would be incredible. But to get there, again, we have this pesky obstacle of the black box warning to get over so that many women can access the treatment.
I'm sure you're much like I am in my practice. I have a lot of older women, women in their 80s even, and I started them on vaginal estrogen because their main issue is local burning when they urinate, dysuria, and recurrent UTIs that send them to the emergency room or get them hospitalized. And using a little bit of low-dose vaginal estrogen, definitely, the studies are out, right, that show definite improvement, reduced risk of UTIs with the use of vaginal estrogen. So again, this misconception of I'm not sexually active, ergo I don't need vaginal estrogen. It's about your personal pelvic health, whether you want to share that with someone else or not, right? It's about we use cream and things like that on our faces, and we do other things to try and improve the quality of our bodies, and that's just a piece of it. But that's a really important point, this issue, too, as you already mentioned, recurrent UTIs and how it really has, especially in postmenopausal women and elderly women, become a bit of a health crisis, right? It's costing so much money to our healthcare system to try and help these women where the issue really is about better prevention.
Absolutely. And as far as the costs are concerned, that's where you can really hook these through the legislative advocacy. So UTI related expenses will consume a third of the total Medicare yearly dollars spent on geriatric patients. And the prevalence of UTIs in women is 20%, which is nearly double the general population when they're above the age of 65. And, 60% of adult women will have a urinary tract infection in their lifetime. And those UTIs account for 7 million hospital visits annually. And of course, not all of them will be a result of women with GSM and postmenopausal recurrent UTIs, but a lot of them will be. And so if you can get these women access to this medication, that's going to definitely impact Medicare, and it's going to be better for the Medicare yearly spending, and everyone benefits. Republicans, Democrats, they all benefit. And we've actually had really great legislative advocacy. So we had a Dr. Powell, who's one of our SUFU members, he was able to get his state legislators to accompany him to the FDA and to have a meeting with the FDA to underscore the importance of this. And the FDA was really emphatic on the fact that in order for the label change to occur, they really needed to see not just legislative advocacy, which we work on. We need to see professional societies and clinical advocacy, which again, that is so much stronger. We have advocates like Kelly Casperson, Rachel Rubin, advocates who come from ACOG and other societies who are really, really emphatic on the benefits of estrogen. And they say that on the New York Times, on social media, in their practices, et cetera. So we have that piece of the puzzle as well. And then the third piece is the citizens themselves. So patient advocacy as well. When that citizen petition or that label change is filed, there's a period of time in which there can be public opinion on the matter. And that's when the patient stories, patient testimonials also come into play. And so the FDA was very explicit about that. They want to see all of that. They want to see all of that. They want to see it in a really nice little package. They want to see that legislatively there's support. They want to see that industry is supportive as well. That's a key player. And so that's the other part of our advocacy efforts through the Public Policy Council is to have stronger ties with industry and really encourage them to move forward with these label change requests so that we can get this across the finish line.
Yeah. So what do you think are, besides those efforts that you just mentioned there, to really get it across the finish line, how long is this going to take?
So this is really interesting. And I always talk about this quote. It's from Game of Thrones, and I'm a huge fan. I've watched it a billion times. And there's one character who says, chaos is a ladder we can climb. And I think that the fact that there has been so much change with the new administration, not just throughout the government, but also at the FDA itself. So there's been a lot of change, and I think there is a big emphasis on wins, and this is like a clear win that the administration can get by having this label change occur. There are people that are really enthusiastic about the label change. I think that what gets in the way, as usual with anything related to government, is process. So the process is nebulous and obscure because there's already been a citizen's petition and it's been denied. And so I think the work that's being done right now is to continue to get the word out as we are doing. This episode is a really great example of that. The webinars that you've seen me give for different professional societies, the AUA has been generous to get all of the stakeholders aligned through the Bladder Health Alliance, which you may be familiar with through your work with the Urology Care Foundation. There's a lot of patient advocacy groups and professional societies in that Bladder Health Alliance. We've had a few stakeholder meetings to talk about what this next step forward are and underscoring that we need to have our legislators on board, which many of them are. There have in particular been 2 bills that were put into discussion recently to show bipartisan menopause support. So Representative Yvette Clarke from New York and Mike Kelly from Pennsylvania put a bill through to improve research and access to menopause-related care. Vaginal estrogen is like, boom, straight in the middle of that. And then there's a Menopause Research and Equity Act, which is a Senate bill. Lead sponsors were Senator Baldwin, I believe, and Lisa Murkowski. And that also allocates millions of dollars for menopause-related research and directs the FDA to revisit hormone therapy labeling using up-to-date safety data. So that's where the legislative advocacy has come into play. And professional societies, including the AUA, have been pivotal in getting those things to be at the top of the list for many of the legislators. And then secondly, we have getting the citizens interested, and by citizens, I mean patients, patient advocacy groups, all of these people, the ones that are directly affected by this problem, getting them to to know and request that this occur. A lead organization there is Let's Talk Menopause. Rachel Rubin, again, to mentioning her name, is a key figure there, but there are a lot of other really key figures in industry and Capitol Hill, as well as clinicians who are part of that group who really push and lobby for anything related to menopause, the label change included there. And then you have the providers, and the providers are best represented through their society. So the AUA put vaginal estrogen and the black box warning at the forefront of its most recent advocacy summit. We had some time to talk about the barriers that exist to the label change. And then we also had all of the urologists that were there, all of the patient advocates that were there, sign the current petition in place through Let's Talk Menopause to get further support. And then the last part is industry. I know that Pfizer is in the works for, updating some of their safety data and presenting that for possible label changing. That has been the hardest nut to crack as far as industry is concerned. And, you can think about, they have to be in compliance with their risk management. They have to weigh these things. Importantly, because whenever you request these label changes, there is that risk. And whether it's related to bias against women, because we see that they moved so much quicker and faster with testosterone, that is certainly possibly a part of it. But I think that the process is usually at play when there are equity problems. And so we let the process get in the way of progress.
Yeah, hopefully this allows what happened with testosterone and, on the heels of that, we're able to move a little more quickly for ourselves, in the female arena, because it is amazing how quickly that went, right? You've described nicely the process, all the pieces of the puzzle that have to come together to make this happen. And yet it happened pretty quickly for testosterone. And yet we've been battling this for how long? And really one of the main requests, for the FDA with this black box warning is just to request an update looking at the most recent data, right? To weigh in on this black box warning. Because remember, the data that's being used for this black box warning is from 2002, 2003, from the WHI study, which wasn't even a study to look at vaginal estrogen whatsoever. So it's very misguided in that sense, and hopefully just bringing this more to the forefront and to light that we can make some headway. I did want to mention really quickly, just you already mentioned the Let's Talk Menopause campaign. I wanted to make sure to mention it because that's something that every individual can do. You can get online, look up Let's Talk Menopause. They have a major campaign going on right now that you can sign the petition about unboxing menopause. That's what it's called. But you can get your name on the petition. You can write general stories about maybe patients you've taken care of, or maybe if you have personal stories yourself, you can add to that. But any little piece that you can add to that is helpful. So that's what our listeners are able to do even today to help the process.
Absolutely. And I think that when I look at the success with the Traverse trial, my first instinct is to be happy. I'm a urologist. I'm really happy. There's always a part that gets a little annoyed that women didn't have the same benefit. But when you think historically, one really important tidbit of history is Ruth Bader Ginsburg and her first sex discrimination case. That was Moritz versus Commissioner. And that client was a man. And so the man she represented had been caring for his mother. She was able to show that he needed the same benefits as a man and that a man could also be a caregiver. And I think that is something we can utilize for the Traverse trial as well. Yes, men got testosterone approved before estrogen did. But now we can argue, hey, testosterone is a hormone. The risks, the cardiovascular risks that we're concerning were similar with a similar pathophysiology. So, hey, that's one step in to say, we got to readdress this for estrogen. And then the other risk, that the data is actually strongest for the breast cancer risk, that there is robust data showcasing that there is no increased risk of breast cancer recurrence with low-dose vaginal estrogen. So to me, that just makes it easier.
Just to point out what you said too, because the discussion has been about, the incidence of breast cancer usually, but even in breast cancer survivors, you use the word recurrence, right? There's no risk of recurrence, breast cancer, or increased mortality associated with it. And we have that data today. So thanks for pointing that out.
Thank you.
Well, so this has just really been a very lively conversation. And to recap, I think for our listeners, what we're talking about again is unboxing, right? The menopause, the black box warning, having the FDA take a closer look at current data that exists today that shows first of all, there is a difference between systemic hormones versus local vaginal estrogen hormones and its potential effects, right? But also requesting that they do a deeper dive into the current data and really allow the current data to inform their decisions about black box warning. It does seem not a little, I'm going to take a little out of that sentence. It seems totally crazy to think that there's still a black box warning that exists that's over 20 years old, and no one has looked at the current data to change that black box warning. I almost think that the FDA really should be a rotation, just like we do our AUA SUFU guidelines, right? Or we look at the guidelines of what's the new information every 5 years or so, that they should be doing that for every black box warning, but that's not the case. So it is crazy for the audience to know that the black box warning exists due to data that was misinterpreted in the first place from 2003. And the next point is the data that we have today, based on large registry data, large population-based studies, show there's no increased risk in breast cancer, incidence of, recurrence of, or cardiovascular events, or dementia. We didn't get into the whole dementia issue. That's going to be actually another episode. We're going to talk about the brain fog and the risk of dementia and the use of estrogen there. But, there's no evidence to suggest any of these issues, and yet it's on the black box warning. So we do have data today to refute all of that. And so we're hoping that the FDA is going to listen.
They have to. It's an inevitability. It's not a matter of if they'll listen, it's when. And so hopefully that will happen this year. But, it remains to be seen. The efforts that we're putting in continuously will lead to a label change. That I know.
Well, thank you so much. Somebody has to do this work, and I'm so thankful you're here to do it. And you're obviously so passionate about it, and you do it well. And we're just so thankful for all that you do for the advocacy for everybody, for all urologists, not just women. I know you do things in other arenas as well. So thanks for being on the show.
Thank you again, Suzette. Always lovely chatting with you.
And as I mentioned already, we're having a series of different episodes dealing with different aspects of menopause. And so this is one of those series. So look for these other ones because they're all connecting together. So thanks for listening, everybody. This is Suzette Sutherland signing off.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon-Hess and Yvonne Orgodzinsky.
Show notes and social media by Emma Landenwich and Lindsay Beecham.
Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own, and do not reflect the views or positions of their employers or any entities they represent.